Arthrofibrosis is a condition where joints become stiff and lose their normal range of motion due to excessive fibrous tissue formation. This problem is especially significant in people with neuromuscular disorders, where the underlying nerve or muscle issues set off a cascade of changes in the joints. The resulting contractures can severely limit mobility, making everyday activities challenging and impacting both physical and emotional well-being. In this video, we'll explore how arthrofibrosis develops in the context of neuromuscular disorders, why it's such a challenge to manage, and what current and future treatments look like. Let's start by understanding what happens inside the body when these conditions arise. Neuromuscular disorders are a diverse group of conditions that affect the nerves, muscles, or both. They can be genetic, congenital, or acquired, and include diseases like cerebral palsy, muscular dystrophies, and spinal muscular atrophy. These disorders disrupt the normal communication between nerves and muscles, leading to weakness, spasticity, or paralysis. Over time, this disruption causes joints to move less, setting the stage for arthrofibrosis. Whether the problem starts in the brain, spinal cord, or peripheral nerves, the end result is often the same: reduced joint movement and the risk of contractures. Development of arthrofibrosis in neuromuscular disorders is complex. When joint movement is reduced, whether from spasticity, weakness, or paralysis, the joint remains in a static position for long periods. This immobility triggers the accumulation of fibrous collagen tissue around the joint, making it even harder to move. Over time, muscles may be replaced by fibrofatty tissue, and the joint capsule becomes thickened and stiff. This process not only limits motion, but also causes pain, muscle atrophy, and even bone changes. The cycle of immobility and fibrosis can be difficult to break, especially without early intervention. Neuromuscular disorders are often classified based on whether they affect upper or lower motor neurons. Upper motor neuron injuries, such as those from stroke or brain injury, typically cause spasticity, muscles become overactive and stiff. Lower motor neuron syndromes, like spinal muscular atrophy, lead to flaccid paralysis and muscle wasting. Both types can result in joint contractures, but the underlying mechanisms differ. In spasticity, muscles are constantly contracted, while in flaccid paralysis, muscles lose their tone and cannot move the joint. Understanding these differences is key to choosing the right treatment approach. At the cellular level, arthrofibrosis is driven by an exaggerated inflammatory response. When a joint is immobilized, inflammatory cytokines and growth factors are released, including TGF-beta, IL-1, and TNF-alpha. These molecules recruit immune cells and stimulate fibroblasts to produce excess collagen. Over time, the balance between collagen production and degradation is lost, leading to dense, stiff tissue that replaces normal muscle and joint structures. Chronic hypoxia, low oxygen levels in the tissue, further worsens the problem by activating additional fibrotic pathways. This cellular environment makes it difficult for the joint to recover normal movement. Several molecules play a central role in the development of arthrofibrosis. Transforming growth factor beta, TGF-beta, is one of the most important, as it drives the activation of fibroblasts and the production of collagen. Other key players include interleukins, tumor necrosis factor, and hypoxia-inducible factor 1-alpha, HUF1-alpha. These molecules interact in complex ways, amplifying the fibrotic response and making it difficult for the body to resolve inflammation naturally. In some neuromuscular disorders, genetic mutations can make fibroblasts even more prone to producing scar tissue, further complicating treatment. The main goal in managing arthrofibrosis is to maintain or restore joint mobility and prevent deformity. This is achieved by balancing the forces around the joint, making sure that no single muscle group dominates and pulls the joint into a fixed position. Non-surgical treatments are usually the first step, focusing on physical therapy, stretching, and bracing. These interventions aim to delay contracture formation, improve muscle strength, and keep joints moving. However, the effectiveness of these treatments can vary, especially in patients with severe neuromuscular disorders. Non-surgical management includes a range of therapies. Physical therapy is central, using exercises and stretches to keep muscles and joints flexible. Serial casting and bracing can help gradually increase range of motion. For spastic muscles, botulinum toxin injections may be used to temporarily relax overactive muscles, making stretching and strengthening more effective. Electrical stimulation and vibratory therapy can also help improve muscle function. While these approaches can be helpful, their long-term effectiveness is often limited, and results may vary from person to person. When non-surgical treatments fail to provide adequate relief, surgery may be considered. Surgical options include tendon lengthening, muscle release, and capsulotomy to increase joint mobility. The choice of procedure depends on the specific muscles and joints involved, as well as the underlying neuromuscular disorder. While surgery can improve joint position and function, it also carries risks such as infection, nerve injury, and recurrence of contractures. Postoperative rehabilitation is crucial to maintain the benefits of surgery and prevent new contractures from forming. Contractures in the upper limbs, such as the shoulder, elbow, wrist, and fingers, can significantly impact daily activities like feeding, dressing, and hygiene. Treatment often starts with stretching, splinting, and sometimes botulinum toxin injections. In more severe cases, surgical procedures such as tendon lengthening or joint release may be necessary. The goal is always to improve function and independence, but overcorrection or complications can occur, so each case must be carefully evaluated and managed by a multidisciplinary team. Lower limb contractures affect standing, walking, and overall mobility. Common sites include the hip, knee, and ankle. Early and aggressive treatment is important to preserve function. Physical therapy, bracing, and orthotic devices are used to maintain alignment and prevent deformity. In cases where contractures are severe or fixed, surgical intervention may be required. Procedures can include soft tissue releases, tendon lengthening, and even bone surgery to correct alignment. The ultimate aim is to maximize independence and quality of life. New therapies are being developed to target the underlying causes of arthrofibrosis. Pharmacological agents that block key molecules like TGF-beta, TNF-alpha, and HIF-1-alpha show promise in reducing or even reversing fibrosis. Collagenase injections, already used for other fibrotic conditions, are being studied for joint contractures. Other experimental treatments include halofuginon and relaxin-2, which have shown positive results in animal models. While these approaches are still under investigation, they offer hope for more effective and less invasive management in the future. One of the major challenges in managing arthrofibrosis is the lack of standardized criteria for diagnosis and assessment. There is no universally accepted way to measure joint range of motion or to classify the severity of contractures. This makes it difficult to compare outcomes across studies or to develop clear treatment guidelines. Clinicians often rely on a combination of clinical examination, simple tools like protractors, and more advanced motion tracking devices. More research is needed to develop reliable and consistent assessment methods. Despite advances in therapy, current treatments for arthrofibrosis secondary to neuromuscular disorders have significant limitations. Non-surgical approaches may provide only temporary improvement, and surgical interventions carry risks of complications and recurrence. There is also a lack of high-quality evidence, with most studies being small case series rather than large randomized trials. This makes it hard to determine which treatments are most effective for specific patients. Individualized care, guided by clinical expertise and patient needs, remains essential. The future of arthrofibrosis management in neuromuscular disorders lies in better understanding the underlying biology, developing targeted therapies, and creating standardized assessment tools. Ongoing research into molecular pathways and new pharmacological agents holds promise for more effective and less invasive treatments. At the same time, improving rehabilitation protocols and surgical techniques will help optimize outcomes. Collaboration among clinicians, researchers, and patients is key to advancing care and improving quality of life for those affected by these challenging conditions.